and say, will you come?
I do. Did you pick your lunches?
Yeah, the concierge.
No. Well, it's down so I can come on.
Yeah, yeah. And what I do is, if I see any of our staff members there, especially at the height of season, I'll just look at them and say, come on, you're next, even if I don't know them. And they look at me, and like the seasonals get mad, they have an appointment.
Ham, tuna, or your chicken?
Because, you know, there's
Ham, tuna, turkey.
we see such a large number of lacking entitled, arrogant, demanding people during season. So when I see one of us, yeah, right, I'm like,
We'll go ahead and get started. I know a lot of you guys are working today. So I'm Kara. This is Amanda, for those of you who don't know us. We are nurses here at NCH on Pediatrics. So when we were presented with the opportunity to provide education today, we wanted to pick a topic that was not only pertinent to our unique population, but also meaningful to us. So I'm sure everybody in this room has had suicide touch them at some point in their lives. So whether it's a family member or a colleague or even a patient, something that it's touched all of our lives. I know that personally for me, I'll never forget the day I got the phone call that I had a family member that actually committed suicide. So this is something that is very near and dear to my heart. So from the pediatric perspective, the suicide rate has actually tripled since 1960, and it continues to rise. So here at NCH, there are things that we're doing already, but there's things that we can do better to help prevent this. The clicker.
Here are the objectives for our project. At the end of this presentation, you should be able to list 3 red flags for potential suicide risk in a pediatric patient. Explain how to perform a suicide risk assessment for a pediatric patient. Detail nursing implications to ensure the safety of the patient. Describe the impact of social media and technology and cyberbullying and suicide. And describe local, state, and national resources for the patient.
All right, so we want to start off with a couple statistics, a couple quotes to kind of get you thinking. So approximately 1,500 suicides occur in inpatient hospital units in the U.S. each year. So think about that. That is in the hospital. So that's a little more than 5% of all of the suicides that are committed in the United States each year. So that's pretty scary to think about. These are the patients that we're taking care of. And to go along with Joint Commission, since 1995, suicide continues to be ranked in the top 5 most frequently reported events by the Joint Commission. So for the past 10 years, this has been up there in the top 5, and it continues to be up there. So it continues to be an issue. And this one is particularly disturbing. 10% of all children attempt suicide at some time during their lives. And this is according to the American Academy of Pediatrics. So this is a very reputable source. And when we looked at the evidence and did all of our research, these statistics are actually very underreported. So this number is probably a lot bigger than this, because a lot of parents just don't report it, or it's labeled as an accident.
So to get started, we're going to talk about the definitions so everybody's on the same page. Suicide is a death caused by self-directed injurious behavior with any intent to die as a result of the behavior, and a suicide attempt may or may not result in injury. And suicidal ideation is thinking about, considering, or planning for one's suicide. I have some statistics. Suicide is the 3rd leading cause of death between 15 to 24-year-olds. 157. Oh,
You lost it.
there you go. 157,000 children in the U.S. Are treated each year in the ER for injuries related to suicide, while 250,000 adolescents attempt suicide each year. And then this about the youth risk behavior surveillance, that was a study performed by the CDC, where 29.9% reported feeling depressed or helplessness. And when feeling depressed, the patient is 12 times more likely to commit suicide. 17% seriously considered suicide. 13% reported having a plan, and 8 reported actually attempting. And 60% of youth with a suicidal plan will attempt suicide. And this one is showing ages 10 and older in the U.S., the leading causes of death. So where suicide is right here. And this one is showing suicide rates by race and sex in the United States. So this one was interesting that it had Alaskan and American Indian as the highest rated race. And this one shows by race and by mechanism. So for all across the board, firearms were the highest.
All right, so when we talk about suicide in pediatrics, it's very important to consider gender because it is very different, males versus females. Males are 4 times more likely to complete suicide, again, complete, not attempt, versus females. And in fact, in 2014, 81% of the youth deaths were males. That's a huge number. And then females, in 2014, that number was represented 19% of the deaths, the overall deaths. Females, it's typically, with their attempts, they're more likely to have suicidal ideation, and usually the attempts involve ingestions. The only exception to that rule is in underdeveloped countries. They actually have a higher rate of ingestions that resulted in completions with females because of the poor access to healthcare. Okay, and then everybody cringes when you think of Erickson and Piaget and aging developmental stages. But it is very important to consider when you're thinking about pediatrics. So children as young as preschool age can actually have suicidal thinking, believe it or not. Again, this number is often underreported because it's not picked up by parents. Obviously at this age they have a decreased ability to express emotions, and a lot of times all of the studies that we looked at are saying that they're going back and saying that a lot of these self-poisonings that they thought were accidents were actually more intentional than they thought. And a child doesn't have a concept of death as being permanent and irreversible until they reach age 10. Again, think of your developmental stages. Prepubescent children engage in concrete operational thinking. So they have very little ability to think abstractly. They're not aware of the consequences for their actions, and they have a limited ability to problem solve. So that kind of right there gives you an idea of how this age could have a higher rate of suicide. And then also they're unaware of the degree of lethality. So that's why it's really important if we have a patient that comes to the emergency room, we may have an 8-year-old that took 5 Motrin. It's really important to discuss with the family and discuss the patient what the intent actually was, because they may not understand. They may think that 5 Motrin, maybe they intended for that to kill them, to result in injury. Okay, and again, more on development. So as far as suicidal ideation, it has the lowest prevalence in ages less than 10. That's not really surprising. It increases at age 12, and then there's a rapid increase at ages 13 to 17. Suicide attempts, again, not completions, peak at age 16, and then suicide completions actually continue to increase through adolescence, and they peak at the early to mid-20s.
Okay, I'm going to talk about some suicide risk factors. So if any of your patients, when you're assessing them, have any of these, it's important to mental note that for later. So a family history of suicide, previous suicide attempts, a history of mental disorders, history of alcohol or substance abuse, feeling of hopelessness, impulsive or aggressive tendencies, isolation from others, barriers to mental health treatment or unwillingness to seek help, and physical illness. And here we have 90% of suicidal teens display warning signs or red flags. but a lot of them, especially by parents, are not noticed. So behavioral would be depression, change in appetite, change in school performance, hopelessness, decreased energy, loss in interest, giving away some of their prized possessions, substance abuse, or being withdrawn. And events that could lead up to this are disappointments, either school grades, not making a team, social aspects, relationship difficulties either with parents or other schoolmates, losses, a death of a loved one or a close friend, or injury. And some red flags, if you hear any of these: I'm going to kill myself, I want to die, I can't stand living, don't worry, I won't be around much longer, I don't want to burden anyone, my family would be better off without me, or I've had enough, I'm ending it all. Any of those? Yes.
In your research, did you girls find anything out about your relationship to kids being bullied and suicide?
We're going to talk about that.
Yeah.
We're going to talk about cyber suicide
Okay.
and cyberbullying.
And then I have another question. Did any of it, as far as like when cutting, did you guys find out, are they considering that as?
Actually labeled as a parasuicide behavior. So it would be a risk factor, but it's more of a, they actually define it as a parasuicide behavior. So more of a, I don't want to say attention getting because it's all very serious and it's all, needs to be addressed, but more of a kind of a cry for help kind of thing.
So here are some of the protective factors to buffer the patient from suicidal thoughts or behavior. Effective clinical care, either mental, physical, or substance abuse. Easy access to a variety of interventions and support. The family and the community coming together to connect. Support from ongoing medical and mental health care relationships. And skills in problem solving, conflict resolution, nonviolent, and cultural or religious beliefs that may discourage suicide and support instincts of self-preservation.
All right, so nursing implications. So we've all gotten a report from ER where you get a report from the nurse before you and you have a Baker Act. Uh-oh, your heart starts beating fast and you're like, oh man, okay, what exactly do I need to do? So what are the nursing implications? So patient screening. If you don't remember anything else about this presentation, remember to ask. Always ask. If you notice any of those red flags that Amanda talked about, always ask. So suicidality, it's very important to remember that it's a fluctuating state. So what that means is suicide behavior is very unpredictable. Just because a patient came in a week before and had an attempt but didn't actually result in a completion doesn't mean that this time they may actually follow through with it. So it's very important to take it very seriously. It's funny because a lot of the research that I read when I pulled up some of the older articles, because like we said about a lot of the suicides, especially in pediatrics, the data is underreported. But a lot of the therapists, researchers in the early 90s, there was a big push saying you should never mention suicide, you should never mention self-harm around kids. Well, that's been out the door. I mean, obviously we know that. So there's been lots of studies that have shown that asking does not promote thoughts of self-harm. And in fact, patients and pediatric patients that they've interviewed say that it encourages engagement and it shows that the nurses and the doctors are empathetic. Patients actually feel disregarded and like they're being ignored and pushed aside if you don't ask. So don't be afraid to ask. So as far as patient screening, we all have our, the screening in iView, and Amanda's going to talk about that a little bit. But these are just ways that you can kind of begin the conversation. Everyone's kind of nervous about how do you actually ask. So with the adolescent, these are just, some of them are very obvious, but some of them, so you can say in the past few weeks, and again, you're focusing on recent time periods because anybody with a teenager knows a day is like an eternity, right? So you say in the past few weeks, have you thought of hurting yourself? And if they say yes, it's very important to ask if they have a plan. In the past few weeks, have you felt your family would be better off without you? Have you ever tried to hurt yourself in the past? With a school-age child, still important to ask. So do you ever feel so sad that you want to go away and never come back? Because obviously a child of that age developmentally isn't going to understand what you're talking about. And then because depression is linked with suicide, you want to ask, do you feel like crying a lot? Do you feel sad a lot? Okay. This is me here. I'm moving forward.
So for the patient screening, it's recommended for ages 4 to 11 to include the parents in the discussion, and then from 12 to 18 to ask the patient directly. So the adolescents don't report the suicide ideation unless directly asked, so like what Kara was talking about. And it's important to focus on recent time periods, such as weeks or days versus months and years. And this is what we need to do for documentation per our policy. So the suicide screening is done with the assessment and at least once per shift with any behavioral changes, and then the psychosocial documentation is under your IVU. Hourly monitoring by the RN. The patient safety tech has a form that they complete hourly, but it's important to remember that the patient safety tech is usually only a high school age education level, and that person may not recognize as much as we would. And the ad hoc form is suicide prevention. That one needs to be completed each shift, and this is the main thing, is to make sure as soon as that patient gets to the floor, we get the psych consult entered.
I did that one for Roseanne. Yep, no problem. Okay, so again, talking about screening. So this is a really interesting study that we found, and this was done over a couple of years, and it's talking about screening from the child's perspective. So we kind of know how families feel about it, but let's dig a little bit deeper and see how does the child, how are they going to respond to it? So Nationwide Children's Hospital, it's a hospital I think in Ohio, and they did this study over a couple-year period. And what they did is they interviewed every single pediatric patient that came into the PEDS ER. And they did universal screening across the board for everyone. So what they found is that 90% of the participants, again, these are pediatric patients, supported the screening. In other words, they were okay with it. They found that most children had never been asked about these kinds of thoughts and feelings before. The patients, the kids reported that they felt a special sense of connection with doctors and nurses, and they really felt like they could talk to them. And a lot of them even said that they felt like they couldn't talk to their family about it. They weren't comfortable with it. And up to 10% of the people that they interviewed actually reported having feelings of feeling isolated and feeling alone. And this is really interesting. These are quotes from actual children that they interviewed. So a 10-year-old says, "If I seem depressed, the nurses can help." So there you go, we can make a difference. If you don't ask, you'll never know. Pretty simple, but pretty right to the point. Kids open up to nurses and doctors because they're helping them. And then a 17-year-old says, "Some kids are too scared to tell their parents and should have someone to talk to." And we thought this one was really interesting too. So this is a 16-year-old psychiatric patient with a long, long history of suicidal ideation and multiple attempts in and out of the psych hospitals. And he said, "If someone had asked me when I was younger, I might not have these problems now." So think about that.
So are you screening everybody? Like
No, this study was screening everybody.
Okay, but
Here at NCH, we're supposed to, you're supposed to be screening if you see any risk factors. So any red
Okay.
flags, any risk factors. Jean's not screening any of her NICU patients. Give me my pinky back.
in labor, you always have to screen for abuse. Every single patient that comes into triage, you've got to ask about being sick.
And the Joint Commission standard is in the ED, anyone that comes in for behavioral health issue, anxiety, depression, chief complaints, any substance abuse, including alcohol, we suicide screen them in the ED. And I don't know if it's like that on the admission history as well, if there's a time for that.
It does pop up.
So it's on that,
It's
yeah,
yellow
so.
on there too.
Because it's required on the admission history.
And we always,
Should have asked that question in order to do it again. Show
And-
them the reason it's-
and we always screen psychosocial. And then obviously if there's any kind of red flag, we're going to talk to the physician and talk to the family about it. Okay, and then this is kind of a useful mnemonic. It's good for kids, but it's also good for really any patient. So there was a nurse at Cincinnati Children's Hospital. I'm going to give her credit, Kathy Shrunk. So she did a big suicide prevention program, and she came up with this mnemonic to talk to kids about suicide. So pretty straightforward, but the L is look and listen for signs of depression and suicide, so the things that Amanda was talking about. A is ask questions. So again, if somebody is coming to you, you need to find out if they have a plan. What is their intent? Make sure you support the person. The worst thing you can say to a child or a patient, anyone that says, I want to kill myself, the worst thing you can say is, no, you don't really feel that way. You want to make sure that they understand that you're accepting of their feelings and that you're there to help them get help. So the T, tell someone get help, and that's more than just giving them a phone number on discharge. Make sure you follow through and have someone that's going to follow through with them.
Okay, this is about some patient safety. So the main thing is to remember patient rights. Just because they're a Baker Act or they may be suicidal and be on a Baker Act, have a sitter, that we need to remember that they still have rights as a patient. One-on-one monitoring for suicide risk, and it's important to know that RNs can initiate suicide precautions per our policy. That doctor does need to be notified about that immediately. Then someone would need to be within arm's length of the patient at all times, including bathroom procedures and family visits. During our research, we found that most of those 1,500 incidents that happened in the hospital were in the bathroom. So it's important to make sure that they are monitored. And we need to search their belongings when they come in, and if the family brings them anything. It's important to check all their belongings with that. And then another thing that we hadn't thought about was bathing. So depending on if we have a doctor order, if the patient can shower, bathe, whatever, it needs to be at least 2 RNs in the room with them, and then gender specific if possible. And we just need to do our best to try to get get that, set up for the patient, and collaborate with the patient. If they say it's okay that if it's a male patient and they say that it's okay that 2 female RNs are the ones that are going to watch them, then, as long as that's established. And this is some environmental things. We need to remove anything that's not medically necessary from the room. As far as food service and meal trays, the order needs to put under special nutrition requests. And then it'll be Baker Act paper products only. So they'll bring plastic utensils, and they'll bring it on a regular tray, and then it'll have a styrofoam tray underneath of that, so they won't actually get the hard plastic tray. And then just notify your hostess and work with them. Cell phones. This one had been a wishy-washy thing on our unit, is can they have the cell phone, can they not? And it's ultimately up to the doctor if they think that it is going to affect their health. If it's, if they think they're going to be on social media and talking to friends or trying to find ways to commit suicide, then it needs to be taken away. But it's ultimately the doctor's order. And then paper trash bags, we can get those from housekeeping, and remove the gloves from the room. We've just been putting them outside of the room. And consistency so if I'm the night nurse and then Kara comes in, it's just making sure that we're on the same page, so that it's not, well, this nurse let me do this, and this, And communication. Nurses are often the patient's first contact. They need to be the patient advocate, establish rapport, maintain therapeutic relationships, try to give them as much privacy as possible with a private room. Of course, they're going to have somebody with them, a sitter, somebody in the room always, but as much privacy as we can. Respect, non-judgmental, actively listen to them, support, and ask open-ended questions. And language barrier, It's important to have an actual interpreter or use the language line, use our resources, and not have the family interpret so that things don't get misconstrued along the line.
Or the housekeeper.
And still maintain their privacy and protect their dignity.
Okay, so, and then thinking about cultural differences, we serve a very diverse population here in Naples. So again, this is by no means meaning to stereotype these groups, but just telling you about some of the beliefs that some people believe in these certain groups. So Amanda talked about how American Indians and Alaskan have one of the highest suicide rates. So they believe in traditional healing, and oftentimes there's a stigma or an embarrassment associated with suicide, and you kind of see that with a lot of these groups. Members of the Asian cultural group like to focus on somatic issues, like to focus on physical problems, and they don't really want to talk about the psychological issues. Members of the Latino population, family is huge, and a lot of times they'll seek help from family first, and a lot of these parents fear that they're going to be blamed or their child's going to be taken away if they present to a doctor that their child has some kind of mental illness. And then for the Haitian culture, some of them believe that depression results from possession by spirits. So that's why it's really important to get the religious leader involved in their care. We've had a couple instances on PEDS where we have been kind of at a wall and couldn't make a decision as far as delivery of care or plan of care, and once we got the religious leader involved and from the community, we were able to move forward and everybody was accepting of the plan. So again, mental health stigma with this population also. And then Hinduism, Buddhism, a lot of these people believe that suffering and suicide is karma and that it's unpreventable. Okay, so as far as family support, because here at NCH we do provide family-centered care, so it's very important. Family interaction should be encouraged, but again, remember your patient rights. It shouldn't be forced. Families are encouraged. You should begin the conversation about safety at home. So begin to talk about removing or securing firearms at home and locking up those medications at home. Most of our patients, if not all of our Baker Acts, will go to a Baker Act accepting facility. There's a rare occasion that Baker Act may be lifted. And again, they'll get that information at the psych facility, but it's important to begin that conversation so that families can start planning. Most suicides, I think you guys are aware of this, occur either shortly after discharge or shortly before discharge. Susan actually told us that. And then again, it's really important to keep an eye out. Family and friends, again, patient rights, they're allowed to have people come and visit, but kind of let them have a little bit of control over that. If you notice a change in behavior, a change in affect when certain family members come in, just keep a close eye out for that.
How do you deal with the teenager that doesn't want their parents there, or?
Well, you know, at that age, we do try and include the family, but if the teenager doesn't want the parent there and it's a threat to their safety, then obviously the doctor is going to be in constant communication because they're still a minor. But if they don't want them there, I mean, if it's harmful to them, then
We deal with that a lot in ED, especially in that acute phase. They're pinning mom against dad anyway, so we just sit down and talk with the parent, keep them informed, and say, if you're going to come in here and your kid's going to fight with you, it's just going to make things worse. So we still make sure the patient, the family is the first point of contact, so mom and dad are always in the loop. And it just gives the kid a little bit of control, and usually if they say no, they don't want mom and dad in the room, usually mom and dad are okay with it. You just have to make sure you communicate with them. Because all they do is parents have forced their way in, and then we're calling security because then they're fighting. I mean, they're getting into an argument.
And then it's a safety issue for the staff too. So, and in fact, like when a patient gets transferred, and you guys probably don't know this, you don't deal with it as much as the rest of us, but when a patient gets transferred, even a minor, you don't need a parent. Obviously, we're going to call them and let them know that they're going to David Lawrence or wherever, but the parent doesn't need to be there. In fact, they go via sheriff's office, and they come pick them up, and they don't even need them there for intake.
Okay.
We usually provide them with the phone number, but Yep. And then coping activities, very important. You want to include the family. So obviously something that is age and developmentally appropriate. So drawing, reading, physical play. We actually had a recent Baker Act and Arts and Healing. I don't know if any of you guys utilize that. I think they're at downtown and north, but great, great, great resource for these families and for these patients. So we had a family that came in and they were so focused on the acute situation, and Arts and Healing happened to come in and she dropped off something simple like a little activity pack with cards. And so when the patient was awake and able to communicate with us, she woke up and she saw all the cards on the door, and that made a huge, big difference to the family and to the patient. Okay, and then a little bit from the patient's perspective. I think it's really important to consider how you would feel in this situation. So this was a descriptive study that was done in 2012, and they went in, they interviewed patients that were in psych facilities. It was more older, like teenage type patients, and then young adults, like early 20s. So common theme, helplessness. They feel disconnected with the staff and with themselves. They feel like the staff doesn't really care about them, and they feel like a lot of times the staff hates them. They feel isolated. One patient actually said he felt like an animal at the zoo. So that's terrible. We're taking away everything, and they have no control. They're literally locked up against their own will. They're removed from their familiar environments. They're removed from family. They're removed from friends. And we tell them when to eat. We tell them when to take their medications, what medications to take, and when to bathe.
So suicide and cyberbullying. So with emails, texts, internet chat rooms, things are instantly distributed. The perpetrator can be anonymous and have no remorse for the person that they're hurting. Children are 40 to 60 times more likely, or 40 to 60% of kids are reporting being cyberbullied, and 2 times more likely to commit suicide among school-age children that have access to cyberbullying. Only 16% of these kids are telling their parents what they're actually doing online. And this is some stuff about the suicide pacts. It's where strangers attempt suicide in similar ways, are all around the same time. Cyber suicide accounts for as high as 1/3 of all suicide attempts. YouTube videos, suicide chat rooms, unregulated stuff. In Japan in 2008, 208 people were killed because there was an internet recipe for a bathroom cleaner. But it not only killed the person that made it, it killed everyone else in the home.
And first responders.
And then media sensations. So we've seen a decrease in that, but it's still prevalent. Last week there was a hanging in Fort Myers, and seeing that on the news can trigger different things with these kids.
All right, so what community resources are out there? So again, most of our patients do go to Baker Act accepting facilities, but it is really important as the nurse, you're kind of the link between them and the community, so you need to start talking about what's out there for the families. So as far as for cyberbullying, there's a lot of good resources out there. So stopbullying.gov is a government regulated resource, and they actually have an app, the No Bullying app, KNOW, No Bullying. It's really interesting. They have a kid version and then they have an adult version. So for adults, it tells them, how they can talk to their kid if they feel like their child is being cyberbullied. And for the kid, it gives them tips on how to talk to people that are bullying them. WiredSafely.org is another internet-based site. It is one of the largest sites, and it has information related to cybercrime, cyberbullying, and internet security. And then Facebook, everybody's on Facebook. So, everything couldn't have happened at the more appropriate time. As we were actually putting this PowerPoint together, this is a post from an acquaintance, a friend that I knew in the past. and she posted this on her Facebook account. So, interestingly enough, we were able to get her help. She was okay. But Facebook actually has a help center link, and they're plugged into the National Suicide Hotline. So if you ever see something like this, you can go to the help center link and you can report it, and then it gets dispatched to local police. And that's what happened in her situation. She was able to get help, and she's better now. But interesting. Timing is everything. The national resources. Everybody needs to know the National Suicide Prevention Hotline. It's 1-800-273-TALK. It's 24-hour access. Youth America Hotline is kind of unique. It links peers to peers, and obviously there are peers that are trained and that are being monitored by adults, but it gives the teens a way to talk to other teens about how they're feeling and gets them help. Light for Life is another national source that provides education to the community as far as suicide prevention. SOS, there's actually a local chapter here in Naples. It's Survivors of Suicide, but they have a high school-based program too. And then Take 5 to Save Lives is another interesting one. They actually made September 10th is World Suicide Prevention Day. And their big thing is that they push it only takes 5 minutes to learn about the red flags for suicide and how you can prevent suicide and recognize it. All right, and then there's your number again, 1-800-273-TALK. All right, and then local resources. So what's available to us here in Collier and Lee County. Project Help Survivors of Suicide, a great group. I think they actually have, if not, I think they have bi-monthly meetings. So they're local in Naples. Collier County has a 24-hour hotline, a crisis hotline. There's CARES Prevention, that's out of Fort Myers. And Hope Hospice has a Healing Survivors of Suicide group, another good resource. And then everyone knows David Lawrence, that's where the majority of our Baker Act patients go. They also have a 24-hour hotline, and that is the Designated Teen Crisis Stabilization Center for Collier County.
Are case managers in the ER under, I think it's community resources, there's all these links that, you know, we can go to print out. I'm curious, have you girls talked to somebody to put all that information
We did talk to
be
Susan
available
Kemper
through-
about it.
via the intranet at NCH? So like,
Yeah, that would be great.
as a nurse in the ER, I can say, here, mom and dad, here's all these resources, and I can just print this off. I mean, I'm used to doing it for people like the plan who don't have health insurance.
Right.
But, you know, I think we're the first line in the hospital is through the ER. It would be nice to have all of that information available.
Do you know anything about that, Chris?
You could probably put the links, you could
I'm
definitely,
not sure which one was the whole case management one.
yeah, the community,
Check it out.
Jen Christmeyer, she works, she's one of the lead social workers downtown, and she kind of leads that, so we could probably be ready for, reach out to her and see what she has under there for that, and she can just update it, and we can all access it through the internet, so.
I know Susan was working on a more updated list as far as for pediatrics that she got from Golisano, I think. She's working on that. All right. Any questions? You guys have had really good questions.
I just have one. Someone puts in a psych consult, like on October, like the physician has, psychiatrist has a 24-hour period to get there. Is it the same with the suicide attempt?
I'm looking at Roseanne.
If they're Baker active, there is an opportunity to put in a consult for psych. They do have 24 hours to respond, but if they're medically clear, they may be going to the facility prior to that consult being done by the doctor.
The medical staff policy says if you have just a routine psych, any routine consult, they have 24 hours to put in. Department of Psychiatry, which is all NCH doctors, say they want to just put in the computer, they'll see the patient within 24 hours. But if you have a patient in a psychotic break, schizophrenic break, who needs support now, and you page them, they'll respond. You know, not every crying patient needs to be seen now. They need to be seen within 24 hours. But if you have someone that your doctor can't manage and needs help, they will consult just like any other stat consult.
But they always tell us not to call.
Well, routine consults, you don't
But
call them.
like you say,
And that needs to be, it needs to be doctor to doctor. It needs to be, doctor, the attending doctor shouldn't be calling the nurse from home saying, call psychiatry to get in there now. The attending doctor needs to come see the patient, prove that they can't do anything, and call to get more support. It shouldn't just be on the phone, and to see them now, to get them, because we want the Baker Act lifted, it's not going to happen either, because we only have 2 psychiatrists and a couple of nurse practitioners for a huge service. And just to put it in perspective, in the state of Florida, there's 110 crisis beds for pediatrics licensed. There's 5.5 million kids in Florida. So this is going to, the problem's not getting any better. It's going to always fall on us. That's why Susan's trying to improve our practices, because we can't fix the facility. We can't fix that, so it's...
Yeah, we have kids sitting around for 3 days.
Oh, yeah.
Waiting to get.
I haven't been in the ER for that many days.
I know.
So,
I know.
yeah.
And Roseanne, correct me if I'm wrong, once they're medically clear, the
You
clock
start that process.
starts and it's 72 hours.
You have 72 hours, so the first 24 are the most critical, because on that day 2, that is to start the process where you have to get the psychologist and the psychiatrist back to either hold that Baker Act in place or lift it. So we have to kind of be in contact with you guys and let you know what hour we're at, who we're calling.
And my colleague downtown, HL, who's the assistant director of the ER downtown, is also a social worker. And per this Baker Act law, once a Baker Act patient is medically clear, the local receiving facility, by law, is supposed to be within that facility within 12 hours to examine that patient. They are pursuing that with Susan and their administration to work on this because of their influx in there. They don't, and that's the thing, when he told that law to us, we were all in shock, and it's as clear as day in the Baker Act law, but it's something that, behavioral health has been a disaster in this country for hundreds of years. It's gotten better than it used to be, but still, people fall on the rules. So that's something he's told the administration, and they're working to actively pursue, because David Lawrence needs to come see these kids. Because a lot of these kids go to the facility, they're gone within 6 to 12 hours. We know that because we get them back with a second attempt. So we know they're not spending days on end in these facilities, so.
Yep, something needs to change. Our wonderful resources.
And we just want to thank Susan Kemper and Lisa Fletcher for all their help with our project.
Been very helpful.
I want to thank you all did an awesome job. Great topic and very timely. Because how many pediatric Baker Acts do I have this week? I think 6.
Yep.
6 or 7. So very timely.
Yeah.
What about early intervention, like, going to schools,
Well,
providing these lectures to the, bringing it to them, something a lot of kids